Hi friends, Dr. Swami Ventrapalli from Attune Health reporting back with another update on COVID. It's been a really long time. We've taken a break from COVID, but I've started seeing the numbers of COVID positive cases rise dramatically over the last few weeks, so I thought it's time to update everyone on my personal views and opinions about the COVID-19 pandemic. So a couple of points about what's going on right now. First of all, we're seeing a ton of cases being reported, a lot of people coming back from vacation over the summer with COVID, a lot of people calling in our office about what they should do, etc. So I know that the COVID numbers are high. Nobody's actually doing the PCR testing, so the official numbers actually may be discordant from what patients are reporting and what my own personal experience is in our clinical practice. Having said that, there's a couple of trends that are emerging. First of all, there's a variant of Omicron lineage known as the EG5, which is about 20% or so of the cases in the United States currently. And this particular variant, like others before it, has learned how to escape the immune system, which is why it's become such a big problem. The good news, however, is that the hospitalization rates in our local hospital and looking at the national hospitalization rates are low. So what does this mean? COVID cases are up, but the hospitalization is low. And as we have covered before in some of these talks that we've done, that's a really good sign. That means that the combination of vaccine immunity and herd immunity from natural infection is working and is preventing our patients from going into the hospital. And I think that's really good news. There is a new variant that the CDC has remarked on and is keeping a very close eye on. It's called the BA.2.86 variant, and it again has a lot of immune escape mechanisms which potentially indicate that it might become a bigger player as time goes on. We'll keep our eyes on that. I do want to share some good news though. Even though we have these new variants and we have an old vaccine at this point, we're finding that there is still immunity. Now let me explain this a little bit. So first of all, there's a new COVID vaccine which is going to be a booster vaccine, and it's expected imminently over the next few weeks to be available at your local drugstore. And though this vaccine was actually generated against the Omicron variants that were in play last year, the good news is that at least 3 different laboratories have independently confirmed that this booster vaccine will have efficacy against the EG5 and even the BA.2.86. So I think that's great news that we should hold on to. So for that reason, I think that if you're in a high-risk group, it would make sense to get the new vaccine as opposed to the original old vaccine. So wait for a couple more weeks. End of September is when I think we're expecting these to be available. The other thing I really want to cover here today in a little bit of detail is that the unsung heroes of the COVID pandemic are actually the T cells. We keep talking about these antibodies and we talk about neutralizing antibodies, which are produced by the mRNA vaccinations or by natural immunity. Antibodies are very short-lived. They last for about 8 to 12 weeks after a vaccination or a natural infection. And if they're circulating and somebody gets exposed to the SARS-CoV-2 virus, immediately they can inactivate that virus. And so they're good for that reason. However, they're short-lived. So within 8 to 12 weeks after the vaccination, we're not seeing the antibodies anymore. But luckily for us, we have something known as memory T cells and memory B cells. The memory B cells are important in producing antibodies on a long-term basis, and they remain in residence in the body. They've already been exposed to the SARS-CoV-2 virus, and they retain a memory of the virus. So the next time a similar virus, the new variant, shows up, they're able to quickly, rapidly produce antibodies instead of waiting the usual 8 to 13 days that would take after an initial infection to get antibodies. Now you're starting to see antibodies within a day, 2 days, or 3 days. So that's the memory B cells. The memory T cells are a different story. T cells also have a memory of either through the vaccination or through natural immunity, natural infection. They have a memory of the previous infection. As soon as they get exposed to the virus, the cell that they infect lets out a distress signal. The cell expresses a piece of the SARS-CoV virus on its surface. And these T cells, which have memory against those proteins that the virus has expressed, now start seeing it on the cell surface and immediately destroy that cell that's infected. So very rapidly, when exposed to the virus again, the T cells and the B cells are able to control the infection well. And I think that that is the most reasonable and clear explanation of why we're not seeing people ending up in hospitalization, or we're not seeing hospitalization rates go up that much compared to the original part of the pandemic. So really what we're talking now is about an endemic infection, which is here to stay, and we are lucky now that we have great immunity among most of our population. However, if you've been listening to my talks, you know that we talk about people at high risk. So you know who you are if you're listening to this. Patients who are elderly, obese, immunocompromised from medicines or from the autoimmune diseases, etc., you're at high risk. And for you, I think staying vigilant while there's a lot of cases is not a bad idea. By vigilance, I mean staying out of crowded places, indoor places which are crowded, poor circulation areas, wearing a mask, etc. is probably wise, and getting the booster vaccine as soon as it's available is probably wise. So I would say that the good news is that even though we're seeing a lot of variants, which in the lay press you'll see, oh, new variant, much more virulent, etc., what they're really meaning is that it's escaping the immune system in a way that was different than the previous variant. But the good news so far is that we have not seen any spikes in hospitalization, and we should hold on to that, and we should also hold on to the fact that our vaccines are helpful, and for the vast majority of patients, they've not caused severe side effects. There are a group of patients for whom they have caused severe side effects, and obviously if you're in that group, you should not be taking more vaccines, or if you're in a low risk group, you may not need a booster vaccine at all. So that answers the question, should we get the COVID booster? And then the other story that I wanted to talk a little bit about is the RSV vaccine. So this is a brand new vaccine that is already available in the United States. And RSV is respiratory syncytial virus, and it causes an upper respiratory and sometimes a lower respiratory infection, which is a pneumonia. And again, it targets vulnerable groups of patients who are immunocompromised, elderly, etc., and can cause a pretty severe illness. And this is the first time that we have a vaccine against it. Now, this is very different than the COVID mRNA vaccinations. It is not an mRNA vaccination. It's actually an older technology where there's a fusion protein, or the F protein of the viral surface is attached to an adjuvant, which then stimulates the immune system to produce an antibody response and a memory B cell and memory T cell response against this virus. So it is protective. It's not an mRNA vaccination, so anybody who's hesitant about mRNA vaccinations, you can still get the RSV vaccination. It's not a live vaccine, so anybody who's concerned about any live vaccines because they're immunocompromised or anything can still get it. So I think those are the positives, and I am recommending it. In terms of timing, I'm going to have a slide on that in a second. I do want to do a little refresher on the flu vaccine because flu season is coming, and historically, the flu has been fairly significant. In the United States, for example, typically between 120 and 150,000 deaths per year. And typically the groups of people who die from the flu are, again, the elderly, immunocompromised patients, nursing home residents, etc. So we see a high level of deaths from the flu. And the virus unlike the SARS-CoV-2 virus, it actually mutates a lot. So the flu vaccine this year is very, very different than the flu vaccine last year. So as a result of this, what we do is we look at the patterns of change that the virus is exhibiting and look at data from the previous years, and then look at, let's say, the southern hemisphere where winter is occurring as we're here ending our summer in the northern hemisphere, and we start predicting what this year's flu vaccine might look like and create a flu vaccine. Again, this is a killed vaccine. It's not an mRNA vaccination. It's old technology, very safe over many years of using these vaccines. And the important thing to know, and you'll always hear this, people will say, oh, I got the flu shot and I got the flu. It gave me the flu. That's actually not correct. What you had was a mimic of the flu. Your body thought that you had the flu, so the immune system went into overdrive and gave you the body aches and pain, which were very similar to the flu. So that's one point about the flu vaccine. The second point is, I often hear that, oh, I got the flu shot, but I got the flu anyway, it didn't work. It's not that it did not work. It prevents death and it prevents hospitalization. And in that, we have great data over 30 plus years, showing us that year after year the flu vaccine does prevent death and hospitalization. So I'm in favor of the flu shot for most patients. I'm required to get it by my hospital. Healthcare workers are expected to get it. And I think it's a good idea for most of our patients who are in the immunocompromised category, and certainly for elderly patients, it's very much recommended. In terms of timing, we now have 3 vaccines that we have to deal with. How do we do it? So I think that the RSV vaccine is available. It peaks early in the fall and early part of winter, so now is a great time to get it. I don't recommend getting it along with the same day as the COVID vaccine. So the new booster for COVID is going to happen at the end of September. So I think waiting about 2 weeks after the RSV vaccine and then getting the COVID booster is probably reasonable. And then I recommend waiting until about October or November or so for the flu vaccine, because typically the peak of the flu season is later on in the winter. And the immunity that you get from the flu vaccine usually lasts only about 3 or 4 months, so it's better to get it a little bit later, in my opinion. So I think that's what I wanted to cover today. The vaccinations, what's happening with COVID and RSV and flu, and I hope you all find this useful. And as always, I appreciate the opportunity of speaking to you about these updates, and thank you always for your feedback.